So on Sunday, July 3rd, 1977, there was an event that has changed the way we practice today. Damadian placed his research assistant, Larry Minkoff, inside his new invention. And nearly 5 hours later, the first whole-body MRI scan of his assistant's chest was obtained. Well, there have been a number of course, remarkable advances in MRI technology since then. And as Shaker already discussed, we're going to be talking a little bit more about diffusion tensor imaging and degenerative cervical myelopathy. So first I'll talk about DTI and myelopathy, focusing on the MJOA and functional outcome, and then talk a little bit about some new techniques and future directions to make this more clinically applicable for everyday use. So, like Shaker mentioned already, DTI is based on the diffusion of water, and we know that cellular membranes restrict water diffusion. The axonal membrane, of course, is the primary source of anisotropy in white matter. And two of the very common parameters that are measured in DTI are mean diffusivity and fractional anisotropy. As was mentioned earlier, anisotropy looks at the organization of the diffusion of water. So on the left-hand side, you see that there's very random motion diffusion of water and low fractional anisotropy. And on the right, where there are axonal membranes, there's high fractional anisotropy and restricted diffusion. We know already that clinical MRI currently is very limited in both myelopathy and spinal cord injury. And while functional assessment in spinal cord injury, for example, the Asia grade or MJOA in myelopathy have modest prognostic ability, we also know that T2-weighted MRI in our clinical scans improves our diagnosis, but doesn't help that much with prognostication. So DTI has potential. Again, you've seen this slide. Axonal sparing is the greatest predictor of functional outcome. And in the setting of myelopathy, we have hypothesized that this is much more like a chronic spinal cord injury model. So the benefits are DTI is sensitive to microarchitecture. Axonal sparing may be correlated with myelopathy outcome as with spinal cord injury. And the quantitative measures may correlate better with functional outcome than clinical MRI. So what we did is to do a prospective study. We did DTI in cervical myelopathy patients. We included measurements before surgery and then functional outcome up to 24 months after surgery, and that 2-year data is still being completed now. These were all adults. They all underwent elective surgery for myelopathy, and we excluded trauma, central cord syndrome, patients with comorbid conditions like rheumatoid arthritis who may not be able to have an MRI, and also, of course, patients who could not have an MRI. So these are the results. We looked first at the preoperative MJOA and looked at preoperative FA, which is fractional anisotropy. And you see that the MJOA correlates with anisotropy at the level of the maximum compression and also at C2, so proximal to that compression. And we see that greater functional status is associated with higher FA values, and this is statistically significant. Next, we looked after surgery. At 3 months, now this graph here shows the fractional anisotropy on the x-axis, and then the change in MJOA on the y-axis. So preoperative fractional anisotropy correlates with postoperative changes at 3 months after surgery in the MJOA. How about 6 months? Same pattern. Lower preoperative FA is associated with greater functional improvement. Again, P is 0.08, and this again at the level of maximum compression and at C2. And what about 1 year? So this relationship holds at a year. Again, lower FA values are associated with greater functional improvement following surgery. Again, level of maximum compression and C2. And we also see that a lower preoperative fractional anisotropy is correlated with a greater postoperative change in MJOA. And that may at first sound a little bit odd, But a recent systematic review looking just at MJOA and outcome also showed that a worse preoperative MJOA is correlated with a bigger change in outcome after surgery. So our next step was to look at physical function, because we all know some of the limitations of the MJOA scale. There's a low ceiling effect, and it doesn't seem to capture some of the dysfunction that patients report. So there are quantitative tests of physical function that some are proposing that we do in a clinic setting. So we decided to study the relationship between DTI metrics and some of these tests, with a hypothesis that the DTI metrics would correlate with the 10-meter walk test, grip strength, and the 9-hole peg test. So we looked at the MJOA and the SF36, which is a general outcome score, physical component scale, 10-meter walk test, which was a mean time of 3 trials, grip strength, again, mean time of 3 trials, and the 9-hole peg test, which is mean time of 2 trials for the dominant hand, and provided a small stipend. These tests take at least 30 minutes to do, so they're quite time-consuming. So we enrolled 26 patients, and of these, 16 also had the 9-hole peg test. And the mean preoperative scores, the MJOA was 13.5, the SF36, 35.4, and these really indicate a moderate level of disability. And the same thing with the 10-meter walk, grip strength, and 9-hole peg test. These are the baseline scores, again indicating a moderate level of disability. What we found is that the DTI parameters correlate with quantitative tests of physical function as well. So the MJOA and SF36 in this study did not significantly correlate with DTI, but I think that's because of our small sample size. Mean diffusivity, transverse ADC, longitudinal ADC, these were significantly correlated with the 9-hole peg test. And fractional anisotropy correlated with the 10-meter walk time with the trend, P.09, and LADC correlated with the 10-meter walk speed as well. So our conclusion from this is that in this small study, DTI parameters do significantly correlate with upper extremity motor function as measured by the 9-hole peg test, and that fractional anisotropy and longitudinal ADC trend towards correlation with the 10-meter walk time and speed. And our hope is to do this with more patients over a longer period of time. So what's next? The quantitative tests of physical function and these patient outcome surveys really add a significant amount of time to a clinic visit, and they're not practical to do in your everyday office. So DTI biomarkers may be more efficient for patient care. So there are some new techniques and future directions that may help us use DTI in the office setting. What are the limitations? Like Shaker mentioned already, the benefits are that DTI is sensitive to microarchitecture and axonal integrity, and that it gives us quantifiable changes, so we have numbers to watch. But the cons, again, are that it's confounded by edema. There's a significant amount of post-clinical MRI processing, so these are not done real time. And of course, the images are confounded by instrumentation. So if a patient's had surgery, you cannot image at that same level very well. So again, with myelopathy, double diffusion MRI is a technique that Matt Buddy's developed that we're using. Again, sensitive to axonal injury and loss, but not sensitive to edema. It's performed during image acquisition, so this can give you real-time data. And again, it's a very short addition to a clinical MRI. And it is more sensitive to functional status after spinal cord injury than spinal cord atrophy is in a rat model. And these are just some early sort of proof of concept spinal cord injury rat model images. So on the left-hand side is the acute injury. On the right-hand side is chronic injury. The columns are T2 weighted signal change, and then DDE, and then histology. And you can see that there's a correlation. You can clearly see on the images, the composite images, that this corresponds to the T2 weighted imaging and the histological changes after a weight drop model in rats. Matt Buddy has also developed a chronic compression rat model where a piece of Teflon is sort of inserted into the spinal canal. And then these images are obtained in a delayed fashion to mimic what we might see in myelopathy. And you can see at the bottom of the graph here, the double diffusion images show they correspond to the compression, the level of compression. The red is the injured tissue, and you can see that injured tissue adjacent to the level of the compression. But both DTI and double diffusion are impaired by instrumentation if there's prior surgery, like I said. And so possible answers are that in our myelopathy studies, we've shown that the proximal changes at C1 and C2 also reflect what's going on in myelopathy. So the DTI images and the proximal cord are correlated with the MJOA. So that might be an option. Kevin Koch in our center is also working on different types of imaging, such as Maverick, to reduce artifact. And this is a lumbar spine, but you can see going across the bottom that he's able to significantly reduce the metal artifact. And so this may also provide us with some options to image right at that level of compression, even in somebody who's had surgery. So to summarize, DTI in myelopathy is sensitive to microarchitecture, axonal injury, and it correlates with MJOA over time, at least out to a year in our studies so far. It also correlates with quantitative tests of physical function. And with the new techniques, the advances in imaging, we may be able to do this real time and around spinal instrumentation, or at least image the proximal cervical spinal cord to give you answers that can be used in clinic. So on Monday, April 23rd, 2018, when this 37-year-old woman with headaches and hyperreflexia comes into your clinic, know that soon you may have another ability, a different type of ability to get an image that will help you prognosticate her outcome. Thank you.